Hi, this is Scott Bergman, broadcasting from the University of Nebraska Medical Center. This is my review of antimicrobial pharmacology. Today I'm going to focus on the spectrum of activity for beta-lactams. By the end of this presentation, you should be able to list which pathogens each antibiotic is most clinically useful against, what route of administration it's available in, and its main pharmacodynamic properties, meaning whether it's concentration or time dependent, and bacteriostatic or bactericidal based on its mechanism of action. Also, the reverse is true. When given common bacteria names, you should be able to select empiric therapy based on the spectrum of activity expected from each drug. I highly recommend the textbook Antibiotics Simplified by Jason Gallagher and Conan McDougall. It explains a lot of these both efficacy and safety tips for these antibiotics. So as an outline for this presentation, I'm going to be covering efficacy today, mainly the spectrum of activity, and a little bit on pharmacokinetics and pharmacodynamics. During class, I go over more of the safety parameters, including side effects and drug interactions. It's also very important when selecting antibiotics to know about the cost and convenience of each dosing regimen. This is beyond the scope of this lecture, but is something you'll find important in clinical practice. So I will bring it up occasionally to explain why we choose one antibiotic over another more often. This presentation goes along with a handout that I have that lists each of the common antibiotics along with bacteria that are commonly encountered in practice. You can see from the top of the antibiotic chart that I have gram-positives, gram-negatives, and anaerobes or atypicals, and have broken it up that way. And then you should be able to know the basic microbiology and morphology of each organism on this chart. So, like Staphylococci grow in clusters, Streptococci are pairs and chains. They can be either beta hemolytic or alpha hemolytic, and the spectrum of activity differs based on that classification. And then within the gram-positives, the last category is Enterococcus, where I have Faecalis on the top and Faecium, or both species that are commonly encountered, on the bottom for the non-beta-lactams. In gram-negatives, most of these are rods, but those that tend to cause respiratory infection, like Haemophilus and Moraxella, they can appear as cocci or coccobacilli. But the enteric gram-negatives, and along with the non-enterics like Pseudomonas, that was what I want to focus on for this lecture. Those are always appear as rods. Anaerobes can be either gram-positive or gram-negative. For this introductory class, I'm not going to have you focus on the differences between those, but be aware that Clostridium difficile is not included in these spectrums of activity. This is Clostridium perfringens and the other species that cause invasive infection. Then the atypicals, focusing on those that cause respiratory infection, such as pneumonia. Now that we've covered that basic structure of how I like to go over antibiotics, I'll start into each class on the chart in general order of their approval, and occasionally I'll go out of order based on their spectrum or their category. Now for the penicillins, going way back to penicillin G and the oral version penicillin VK, these were the first antibiotics discovered. They worked really well for both staph and strep when they were discovered, but it wasn't long before Staph aureus developed a simple form of beta-lactamase, an enzyme called penicillinase that would break down these natural penicillins. So today we assume that Staph aureus is resistant, and we focus on the Streptococci. Mainly the beta hemolytic strep, you can reliably treat with natural penicillins. You can also treat strep pneumo in a lot of cases, but it depends on the sensitivity of the organism. These are also the drug of choice, at least the IV formulations or parenteral IM injections of penicillin for syphilis. That's beyond the scope of this particular lecture. You'll cover that more in the sexually transmitted infections class. Next up are oxacillin and nafcillin, or dicloxacillin, which is an oral version of that. These are called anti-staph penicillins because they are considered drugs of choice for methicillin-susceptible Staph aureus. These are stable to that simple beta-lactamase called penicillinase, so they won't get broken down by it. These are also known as a class called the penicillinase-resistant penicillins for that reason. So these are still good for MSSA. They also work for strep, not something we necessarily usually need or think about when we're treating infection. But if you can treat Staph aureus, usually you can treat at least the beta hemolytic strep as a general rule. Now, ampicillin and amoxicillin, these are aminopenicillins. This was the first class that had any gram-negative activity. Unfortunately, broader beta-lactamases have developed and generally will hydrolyze these and make them ineffective. So we no longer think of them as real great drugs for gram-negatives, but they are particularly important. Ampicillin being the drug of choice for Enterococcus faecalis, and amoxicillin has the same spectrum, but better bioavailability, so is the preferred oral option. That can also be used for Enterococcus infection, but it's particularly useful for Streptococcus pneumoniae, so respiratory tract infections that are caused by this. You can give higher doses and overcome some of the low-level resistance that occurs in this organism, which is why amoxicillin is still one of the most commonly prescribed outpatient prescriptions. Now moving on to the broader spectrum, anti-pseudomonal penicillins. Piperacillin is really the only one that exists today, and even that isn't used by itself. But the main point here is that these are drugs of choice for Pseudomonas, and they also work really well for enteric gram-negatives. These are the gastrointestinal microbiota or flora that grow in your gut normally and can spill out and cause infection if there gets to be too many of them in the wrong place. I mentioned piperacillin isn't used alone very much anymore, and that's because it comes coupled with a beta-lactamase inhibitor to really enhance the activity for the enteric gram-negatives like E. coli and Klebsiella. So that's the product that you'll see used widely in clinical practice now. Ampicillin sulbactam and amoxicillin clavulanic acid, they have a similar spectrum to each other, but they don't have that anti-pseudomonal activity. What the beta-lactamase inhibitor does, though, is improve that activity for gram-negatives. So how I mentioned the amoxicillin and also ampicillin had lost their gram-negative activity, well, this helps restore it. That beta-lactamase inhibitor will make the drug useful again. They still aren't real great. They're not as good as piperacillin tazobactam, but for minor infections, they can still work. And it's important to know that they had that natural activity to begin with, and then the beta-lactamase inhibitor restores it. The main organisms that I'm thinking of for this are Staph aureus that has the penicillinase. These aren't drugs of choice for that, but for minor infections, they will work if it's an MSSA, but not an MRSA, because that resistance mechanism is different. The enteric gram-negatives I focused on, especially Klebsiella. All Klebsiella pneumoniae produce beta-lactamase naturally, so ampicillin or amoxicillin will never work on their own for that, but they actually have pretty good activity when coupled with that beta-lactamase inhibitor. They also enhance activity against respiratory gram-negatives, like Moraxella especially, and some Haemophilus. That number has been growing that produce beta-lactamase in the last few years. And then anaerobes, in particular Bacteroides, which was a gram-negative anaerobe that usually produces beta-lactamase. This is the first class that has really pretty good activity across the board for anaerobes. Plain penicillin has a little bit against the gram-positive Peptostreptococcus and the mouth microbiota that grow in harmony with aerobes in the mouth. Now moving on to cephalosporins, a few general rules. None of these have good activity against Enterococcus species, atypicals like Mycoplasma, or Listeria, which is a gram-positive rod that becomes important in meningitis. As another point on the atypicals, none of the beta-lactams are going to be effective against those. They're called that because they don't have a really well-defined cell wall. So these drugs all work on the cell wall, and they can't attack that target in an atypical. In the first generation of cephalosporins is cefazolin or cephalexin, the oral equivalent. These are good for MSSA as well as the beta hemolytic strep, like group A and B. So they're a lot like oxacillin and nafcillin in that regard, but they're a little bit better tolerated. And they do have a little bit of gram-negative activity, and we're not focused on that today. Right now, just think of them as good gram-positive drugs. There's also a lot of different second generations, but most of them have fallen out of favor. So I just want you to focus on cefuroxime as the hallmark drug in that class. This comes in either IV and oral, although the dosage is different because of different salt formulations. This was the first cephalosporin to really have decent activity against strep pneumoniae and also the respiratory gram-negatives like Haemophilus. In this regard, it's a lot like amoxicillin. There's another spin-off of the second generation class called the cefamycins. Either cefoxidin or cefotetan are in that class. These are different because they have better activity against enteric gram-negatives as well as anaerobes. And they're really the only cephalosporins that have decent anaerobe activity. Probably not quite as good as piptazo and the beta-lactamase inhibitors, but these are pretty effective for surgical prophylaxis whenever a surgeon is cutting into the gut and wants to protect the patient from that flora spilling out into the abdominal cavity. Now moving on to third generation cephalosporins, ceftriaxone and cefotaxime are the classic drugs. Cefotaxime has been discontinued by the manufacturer due to cost of producing it and low volume. So for right now, I haven't seen that for about a year or two. And it's unknown whether somebody else will pick it up and bring it back to the market. But they have the same spectrum of activity. Strep pneumoniae is really their claim to fame as being good for community-acquired pneumonia. If it's resistant to penicillin, it can still be susceptible to these third-generation cephalosporins. They're also very good for enteric gram-negatives, E. coli, Klebsiella, Proteus in particular. There's another third generation called ceftazidime. This is good for enterics, but it doesn't have very good gram-positive activity. Instead, the key point here is that this is an anti-pseudomonal cephalosporin. It has pretty good activity against Pseudomonas aeruginosa. And that is similar to cefapime, the fourth generation. It is also an anti-pseudomonal beta-lactam, but this one retains activity against strep pneumoniae, so it's kind of like a mixture, a combination of ceftriaxone and ceftazidime spectrum. It also has a little bit of enhanced activity against enteric gram-negatives. As we get further down the list of the common species, Anaerobacter is a genus that you'll encounter that this is stable against. Now, ceftaroline is the next cephalosporin approved. It's not technically called the fifth generation by the FDA, it's just called advanced, but most people in practice will refer to it as a fifth generation. This is a gram-positive drug. It adds MRSA activity, so they've designed the structure to be able to attach to the altered penicillin binding proteins of that organism. It's also really good against strep pneumoniae, but because we don't have much resistance to ceftriaxone or the alternative drugs for pneumonia, I haven't used it much for that. Now there's a few new cephalosporin combinations that have come out. Ceftolozane tazobactam is IV only, and it's particularly good for Pseudomonas, the multi-drug resistant strains that are resistant to piperacillin tazobactam and the Carbapenems. It also has the beta-lactamase inhibitor tazobactam that you may remember with piperacillin. So that means it does have a good enteric gram-negative activity, but don't let this one fool you with anaerobes. Because the cephalosporins don't have good anaerobic activity to begin with, that tazobactam isn't going to restore activity to them. It could work for Bacteroides, but not Clostridium. Don't worry about the details here, other than to know that it's not as good as the other beta-lactamase inhibitor combinations for anaerobes. Ceftazidime avibactam is a little bit different. It has an enhanced beta-lactamase inhibitor. It actually inhibits the broadest spectrum of enzyme called Carbapenemase, at least the common form that is in Klebsiella. This is really common in some parts of the country, so will really vary based on where you practice. Here in the Midwest, it's relatively rare, luckily. This drug also has pretty good activity against Pseudomonas. We see more Pseudomonas than we do Carbapenem-resistant Enterobacteriaceae, so we tend to use ceftolozane tazobactam more than ceftaz avibactam, and that's mainly due to the price of this avibactam being more expensive, and it's about the same from an efficacy standpoint with those Pseudomonas that we see. Now, just to summarize some of the beta-lactamase resistance mechanisms I've been mentioning, going back to penicillinase, that's really only for Staph aureus, and that's what breaks down the natural penicillins and the aminopenicillins, but not oxacillin, nafcillin, or the cephalosporins. The regular beta-lactamase, what I like to call it, that's what's in the enteric gram-negatives like Klebsiella and E. coli, and the respiratory pathogens like Moraxella produces it most of the time, Haemophilus some of the time, and then anaerobes like Bacteroides. These will break down most all of the penicillins that don't have a beta-lactamase inhibitor, plus the first two generations of cephalosporins. Now, the third generations would be stable to that, ceftriaxone, but then the bacteria became smarter and produced broader beta-lactamases called extended spectrum beta-lactamases, or ESBLs. So when you hear this term, automatically think of ceftriaxone resistance. Third generation cephalosporins don't work. Ceftaz won't work. Depending on the type, usually cefapime won't work either. And even the beta-lactamase inhibitors like tazobactam, they don't work very well. It may show susceptible, but in the actual patient, there may be so many bacteria producing that enzyme that it'll overwhelm it. So we don't trust these anymore for real serious infections like bacteremia or endocarditis. But if you have a simple infection like a UTI, some centers will still use this. And cephamycins are another alternative to try to spare using really broad spectrum antibiotics for these relatively simple and non-life-threatening infections. The carbapenemase I mentioned, the most common form is called Klebsiella pneumoniae carbapenemase, or KPC, and broadly the whole category that is called carbapenem-resistant Enterobacteriaceae, whether it's an E. coli or a Klebsiella. CRE is the more generic term. These are resistant to all carbapenems and usually all beta-lactams as well. So that's where avibactam comes in, and there are a couple new carbapenem ACE inhibitors that we'll talk about that go with carbapenems too. But first off, just the regular carbapenems. Imipenem and meropenem are the ones that you'll see today, mostly meropenem. Doripenem was produced as a more potent anti-pseudomonal, but it really didn't have the traction that it wanted to gain, and it ended up being withdrawn from the market, not because it was unsafe, but it was just hard to sell as a brand name drug. Main points here that they work for Pseudomonas, they have good gram-negative activity, including enterics. They're the drugs of choice for ESBL producers. So I said when you hear that term, think resistance to ceftriaxone. And then I said they're not that great. Piptazo and those other broad-spectrum beta-lactamases are not that great. So think Carbapenems for serious infections with ESBLs. They also have anaerobic activity, so in that way they are a lot like Piptazo. Ertapenem is the one that's different. Definitely want to remember this, that this has a slightly narrower spectrum. Still pretty broad with gram-positives, gram-negatives, and anaerobes, but it does not have activity against Pseudomonas aeruginosa or Anaerococcus. And it also doesn't work against Acinetobacter baumannii, which is a hospital-acquired infection that can be really resistant, something that grows in the environment and can colonize patients. I don't focus on that for entry-level students trying to learn antibiotics, but it's something you may hear of. Now, those new Carbapenem combos I mentioned, there's 2 of them out now, Meropenem with Beta-Lactam. Both of them are IV only, just like the Carbapenems. These are considered more active than colistin, which we'll talk about as a really old and toxic gram-negative drug that we're trying not to use anymore because of acute kidney injury with it. So these are more effective for CRE, the carbapenem-resistant Enterobacteriaceae, along with being more safe, but they're also quite a bit more expensive as well. Relebactam is the newest agent in this class that's paired with imipenem, cilastatin. Cilastatin was with the regular imipenem as well to help it prevent it from being broken down by the kidneys. Similar activity for enterics. This claim to fame may be that it's a little bit more active for Pseudomonas against carbapenem-resistant strains. Still too new to really know how well that's going to play out in practice. But just remember that these combos are good for CRE, I think, is the first thing you need to know. And then the last, Beta-Lactam, is really a variation called a Monobactam aztreonam. It's IV only. It's good for enterics and Pseudomonas, but it's essentially the same as ceftazidime, and ESBLs will break that down as well as aztreonam. So think of it like ceftazidime. The advantage is that it's not actually a beta-lactam, so some people that are allergic to penicillins and the other cephalosporins may not have a reaction, but it's not used very much, so it's fairly expensive, about $200 a day. So you don't see it a whole lot, but it is nice to have when you have a patient that really needs it. So that wraps up the beta-lactams. This is the back of my antibiotic chart showing the mechanisms of actions. So we talked about the upper right-hand corner, and these all work on the cell wall today. These are considered time-dependent because of that cell wall action. You have to wait for cells to grow over time, and it depends on how high the concentration is for how long. It doesn't need to be super high, just enough to be able to kill the bacteria for about half the dosage interval, and we'll talk more about that in future classes. So next we're going to talk about the non-beta-lactams. So I'll wrap this up, and if you have any questions, here's my contact information for you to get a hold of me.